Cisplatin sensitivity and acquired resistance in adult germ cell tumor. Exquisite sensitivity to chemotherapy distinguishes germ cell tumor from most other cancer. Level of p53 mutation proteins are elevated in all germ cell tumor except teratoma. So to maintain genomic integrity, embryonic stem cells have a high sensitivity to DNA damage, suggesting that high levels of wild type p53 germ cell tumor may be intrinsic to their germ cell nature. p53 mutation uncommon in germ cell tumor. However, using whole genome sequences, mutation of p53 MDMT2 were found in 24% of the cisplatin resistant tumor compared to 2% of cisplatin sensitive in a series of 180 patients from a single center, suggesting a role of treatment failure. So mutation of BRAF including V600E mutation have been detected in small percentage of NSGCT, and BRAF mutation were most prevalent in mediastinal. Okay, BRAF mutation that was most prevalent in the mediastinal primary tumor. Late relapse cisplatin resistant NSGCT is suggesting a role of chemoresistance. Further study is needed to define the prognostic significance of BRAF mutations and whether V600E mutation can be therapeutically targeted. A high ratio of pro-apoptotic BAX to anti-apoptotic BCL2 was found in invasive germ cell tumors and may explain the rapid apoptosis response to DNA damaging drugs. However, BAX BCL2 ratio was not appropriate for the associated with the treatment outcome. Upregulation of the phosphatidyl inositol 3 kinase AKT pathway through the platelet-derived growth factor alpha and beta pathways has also been implicated in the cisplatin-resistant cells with the restoration of sensitivity with Down's regulation of the PDGF signaling. Using a hotspot analysis for genetic mutations in DNA extracted from the patients with cisplatin-resistant and cisplatin-sensitive germ cell tumor, mutations in the KRAS, HRAS, PIK, PI3K and AKT were found exclusively in patients with resistance, accounting for approximately 25% of the cases evaluated. Emergence of cisplatin resistance may be intimately associated with the expression of genes and pathways responsible for the lineage differentiation in NSGCT. In other words, intrinsic to germ cell biology rather than the result of specific mutation. IHC, if we see, spelt like transcription factor 4 is expressed in almost all germ cell tumors and has been found to have positive in GCNIS, classic seminoma, spermatocytic tumor, embryonal and yolk sac tumor, choriocarcinoma, teratoma. Octamer binding transcription factor 3-4. Octamer binding transcription factor 3-4 is variable expression in GCNIS, classic seminoma, embryonal carcinoma, yolk sac tumor, spermatocytic tumor and choriocarcinoma, teratoma. They are usually negative for OCT3-4. Cluster of differentiation 117 KIT 117 that help highlight GCNIS and classic seminoma. CD30 and this SRY box transcription factor 2 and keratin help in diagnosis of embryonal carcinoma. SALL4 glypican 3 they are found in positive in yolk sac tumors and in tumors of unknown primary or those presenting as a retroperitoneal mediastinal mass. SLL4 OCT3-4 CD117 SOX2 CD30 and low molecular weight keratins all useful in distinguishing germ cell tumor from non-germ cell tumors. Staging. Most widely used system for staging of testicular cancer is the TRM classification endorsed by the AJCC, UICC, and important distinguishing of germ cell tumor is the inclusion of the S classification, that is S0 to S3, signifying serum tumor marker elevation, and there are 3 stage grouping of TNM S classification. Stage 1 is classified confined to testis, stage 2 is confined to the retroperitoneal node with the serum tumor markers in the good prognostic range of S0 to S1. In stage 3 with metastasis that extend beyond retroperitoneum or extranodal in location, and stage 3 NSGCT also include patient with serum tumor markers in the intermediate to poor S2 S3. So this is the staging of TNM. PT0, no tumor cannot be assessed. T0, no evidence of primary tumor. TIS, intratubular germ cell neoplasm. T1 is limited to testis epididymis without vascular or lymphatic invasion and may invade the tunica albuginea but not invade tunica vaginalis. Then T2 is limited to testis. PT2 limited to testis epididymis with vascular or lymphatic invasion or tumor extending through the tunica albuginea, involvement of the tunica vaginalis. PT3 invades spermatic cord with or without vascular lymphatic invasion. T4 tumor invades scrotum with or without vascular lymphatic invasion. And 0 no regional lymph node. N1 metastasis to more than 2 cm in the greatest dimension lymph node. Multiple lymph nodes, none greater than 2 cm. And 2 metastasis to the lymph node more than 2 to up to 5 cm in the greatest dimension with multiple nodes, none more than 5 cm in the greatest dimension. And N3 is more than 5 cm in the greatest dimension. This is for clinical. And for pathological node, N0 no regional node, N1 metastasis in the lymph node more than 2 less than 5 cm positive with none more than 2 cm and number is less than 5 nodes, less than equal to 5 to 5 nodes. And 2 is more than 2 but not more than 5 cm in the greatest and more than 5 nodes positive with none more than 5 cm in the diameter and evidence of the evidence of the external extension of the tumor. And N3 is more than 5 cm in the greatest dimension node. M1 distant mets, M1A non-regional nodal pulmonary mets. If non-regional nodal mets is there or pulmonary mets, it is M1A. M1B is distant mets other than the non-regional lymph nodes and distant metastasis other than to non-regional and lung mets, called M1B. And markers, S1 is LDH less than 1.5 to upper normal limit, HCG less than 5000, AFP less than 1000 nanogram per ml. HCG is milli-international unit per liter ml. S2 is LDH 1.5 to 10 times of normal limit, HCG 5000 to 50,000 milli-international ml, AFP 1000 to 10,000 nanogram per ml. S3 more than 10 times LDH, HCG more than 50,000 milli-international unit per ml, AFP more than 10,000 nanogram per ml. So pattern of metastasis. Testicular cancer can undergo both lymphatic and hematogenous dissemination. Lymphatic arising from the testis accompany the gonadal vessels in the spermatic cord, and some follow the gonadal vessels to their origin, and whereas others diverge and drain into the retroperitoneum. The landing zone for metastasis for the right testis is the paracaval and interaortic caval lymph node, just inferior to the renal vessels, and the landing zone for the left testis is in the left is the paraortic lymph node, just inferior to the left renal vessels. Large volume disease tend to progress in retrograde fashion. Large volume disease tends to progress in retrograde fashion to aortic bifurcation and below and outflow along the iliac vessels. Seminoma can spread extensively through the lymphatic system to include retroperitoneum, retrocrural, mediastinal, supraclavicular, cervical nodes, often in the absence of hematogenous mats. And mats to lungs like stage 3A is common, and metastasis to the non-pulmonary organ stage 3B is less common. Serum tumor markers do not affect the stage except in stage 1S. Prognosis or prognosis of seminoma. Hematogenous mats to extrapulmonary organs like bone and seminoma carries intermediate prognosis, and there is no stage 3C for or poor prognosis in case of seminoma. For non-seminomatous germ cell tumor, similar to seminoma, lymphatic spread is most common and usually earliest for the dissemination in NSGCT, and stage grouping depend on both the anatomical extent of the disease and serum markers. Stage 3B is distinguished from stage 2 and 3A on the basis of tumor markers being the intermediate group S2. Stage 3C NSGCT carries a poor prognosis. Stage 3C NSGCT carries a poor prognosis and more often associated with the more often than the seminoma, it involves multiple organs like liver and brain. Embryonal carcinoma in some cases exhibit hematogenous mats to lung and non-pulmonary viscera. Embryonal carcinoma exhibit hematogenous mats क्या क्या जैसे lungs में जैसे non-pulmonary viscera without clinical involvement of the retroperitoneal node. And computed CT chest is necessary for complete staging workup and have a high percentage of embryonal carcinoma. Serum tumor markers, they are important part of staging. S1, S2, S3 we saw already. It's the same.